Good morning and welcome back to JP, Kathy, and the crew here on 1160 AM, KBDT News Talk Sports. And if you are tuned in at 8:34 a.m. on a Tuesday, you know this is our mental health moment. And we are so proud to deliver you this information and open up the conversation and talk about mental illness and talk about how this impacts individuals and families, and talk about solutions. I really like that. We've got, of course, Steve Dunn from the Morgan Foundation with us. Good morning, Steve.
Hello, good morning.
And we've got Patty Gillot from Something for Kelly.
Good morning.
Good morning. And they're with us every Tuesday talking about this and opening up and, ripping that Band-Aid off and talking about a tough topic that we need to talk about. Super excited. We've got Dr. Lutter with us today, and he is in studio live. If you want to call him and ask him questions about this important topic, you can reach us at 214-810-8255. That's 214-810-TALK. Or ping us on Facebook. We're watching our live feed right now on JP, Kathy, and the crew. If you have questions and you want to hear what the doctor has to say or what Patty or Steve have to say, please don't hesitate, because we want to encourage you, again, have this conversation. And we're talking today about something really important as we move into Thanksgiving, and that's just around the corner. And then also as we move towards Christmas and New Year's, these are times of year when food is a big common theme. Obviously, thankfulness and, Jesus's birthday and all those kinds of good things. But food is something that no matter what your financial background, your economic background, your ethnic background, your age, your religion, food is something that is a huge part of the holiday season. So,
Kathy, that is so true. And thank you for bringing that subject up, because we are going to be talking about eating disorders and the stress associated with the holidays. But what we want to do first is to allow Dr. Lutter to explain to our audience about himself. Tell us about your background and your world of eating disorders, Doctor.
Well, thank you very much for having me today. It is a great
welcome.
pleasure to be with everyone. So I received both a medical degree and a PhD in biochemistry from UT Southwestern. Then I did a residency in psychiatry and received additional training in human genetics and neuroscience, and spent about 10 years studying the genetic and neurobiologic basis of eating disorders in universities. I left in 2016 to kind of focus more on clinical care and clinical research, and have been working in the community since this year, doing a private practice to help patients with eating disorders.
Well, so obviously, Patty and Steve, we've got somebody who is absolutely an expert in their field. So let's utilize this time wisely and get down to what are the problems and how we can help. Patty, if you want to kick off the questions.
That's exactly what we need. Thank you, Kathy. What we would like to talk about today is both from the patient perspective as well as from the family perspective, the stress associated with trying to decide how to eat, how to prepare for the holidays. I have a niece I was talking to Michael about who has an eating disorder that started from overeating, and then she actually became anorexic. So, doctor, please help us from the patient perspective, what they can do to help themselves.
Yeah, like Kathy was saying, the holidays are a very, very difficult time of year for most patients with eating disorders. And there's really kind of two major themes that keep coming up over and over again. One is just the meal itself. Patients with eating disorders usually do very well with structure and predictability, and holiday meals are usually at different times. They're in unusual locations. A lot of times you're not sure what is on the menu. So they don't do very well under pressure situations, kind of making decisions that kind of obsess over and over again about what to eat. The second major theme that comes up is sort of interactions with family, especially family that they don't see very often. The most common example of this would be a patient with anorexia who says, or who you say gains, 20, 30, 40 pounds in treatment, they will come back and maybe they won't have seen grandma or an aunt or an uncle for several months, and they're afraid about what kind of comments will be made.
Oh, I didn't even think about it. So you're saying somebody who has had some success, being at more of a healthy weight, but then they're worried that somebody who they only see a couple of times a year is going to maybe look at them like, oh, what happened? Or maybe in a negative manner.
Yes. And a lot of times it's not even negative. Sometimes people will make negative comments, but a lot of times family members are trying to be supportive. They will say things like, oh, you look so much better, or you look healthy. But one of the things we know about anorexia is it affects the part of the brain that allows you to sense your own self. And even patients who are a normal weight will still feel like they are overweight, and they will interpret comments like that as that they are overweight or that they are fat or things like that.
Well, so the word healthy, where if somebody said to me, you look healthy, I'd be like, oh, awesome, thank you. In somebody, if you're not in that state of mind, if you're in a different state of mind where you're looking to interpret it, or you can't help but interpret it, that kind of positive comment that was well-intentioned may not turn out that way. Is that what you're saying?
That's exactly right. A lot of times people will misinterpret comments, and we know that this is just part of the illness, that they have a hard time interpreting feedback from other people. So I always recommend for family members to make as neutral comments as possible. It's just like, it's so good to see you. How have you been? How are you doing?
I love you. Give me a hug.
Exactly.
Okay, gotcha.
So those are all really great comments, especially for folks that are struggling with anorexia. Could you give us equal enlightenment for bulimia and how often that occurs during the holidays?
So we do know that eating disorder behaviors increase around the holidays. And I think the major component of that, again, is the unpredictability. Patients who are on structured meal plans tend to do very well. And that's typically 3 meals and either 2 or 3 snacks a day, depending on what the dietitian prescribes for them. When patients get out of that regular routine, it tends to trigger any number of eating disorder behaviors, whether it be restriction. More commonly, it's binging. Binging will then sometimes lead to purging behaviors like self-induced vomiting or abuse of laxatives or excessive exercise or things like that. So the holidays are a notoriously difficult time, like I said, because of the difficult time that patients with eating disorders have with adapting and being flexible around meals.
Doctor, one thing we have not addressed yet, and unfortunately I found out about this from personal experience. A person with an eating disorder who's had it in their life for quite a while, for days, perhaps even weeks leading up to Thanksgiving or Christmas, have these negative thoughts in their head. Oh my God, I'm going to have a table full of food right in front of me. How am I going to possibly handle that? And more often than not, they isolate themselves. They come up with excuses why they don't want to get involved. What would you tell them? How do you get them involved? So
one of the most common things we do at this time of year is we sit down with our patients and we plan what we call a cope ahead. So we try to structure the day to keep it as close as their routine as possible. So that starts off, number one, don't skip breakfast, whether it's anorexia, binge eating, bulimia, always have breakfast. And then if possible, try to schedule the meal times at your regular times, right? So a lot of families will sort of have this large mid-afternoon meal, 1, 2, 3 in the afternoon that sort of combines lunch and dinner. And that makes it very difficult. If at all possible, if you can have it at lunch or at dinner time, it makes it so much easier. One of the advantages of a holiday meal, especially Thanksgiving, is the menus are usually known ahead of time. Everybody sort of already knows what they're going to make. So you can pretty easily sit down and work with your dietitian or your therapist and be like, okay, what fits into my meal plan? We're going to have a side of serving a turkey as our protein. We'll have some vegetables like the green bean casserole.
Right.
We'll have the potatoes as a grain or starch. And then what does that look like ahead of time? So that you go into the day already knowing what you're going to have. For younger patients, 12, 13, 14, the parent will probably just go ahead and plate that themselves before everybody else sits down. For older patients, they will often plate that themselves with some sort of supervision by family members.
Because I know that some of the things they think about is they're imagining a table in front of them, and they've got mom and dad and brothers and Uncle Jake, and they know their plates are going to be absolutely full and elbows are going to be flying. The only sounds you hear are the chomping teeth and the silverware clicking against the plates. And for many, that triggers in their mind thoughts of binging, purging. What would you tell them in terms of how to handle a situation like that?
That's true. A lot of times sensory input will trigger binge eating episodes, right? The smell, the taste, the texture of the food, the surrounding, all of those we know increase hunger cues and will get people to be very hungry. What we now know about binge eating is that is a specific problem with what we would call satiety, or feedback from your stomach and your intestines after a meal back to your brain to tell you to stop eating. So we definitely recommend staying on meal plan, trying to limit sensory input as much as possible, keep the meal plan as normalized as possible, decrease sensory input if possible. So if you can have them, set at the kids' table, off to the side maybe, or at the end of the table. A lot of times patients will have a code word with their family. It'll be like snowflake, and that will signal to them that they need kind of a break, and they need to just get up and remove themselves from the situation so that they can kind of de-escalate and then come back to the table when they're feeling better.
And those are great suggestions. I believe we have a caller. Cleo, are you on the line?
Yes, Kathy, I am.
Good morning. Cleo, do you have a question for the doctor or a comment?
No, I actually have a comment. I like the way that he's approaching this from a point of knowledge from the family. But the fact is, I have noticed in parts of my own family and some other friends that are anorexics or bulimics that most people are unaware, especially the extended families, of all of these things you're talking about. So I feel like it puts a lot of stress, especially on the bulimic or even just the chronic overeaters, because people don't know what's going on. So when they're watching them agonizing and picking very slowly through food and taking forever, to eat,
Right.
Then the negative comments start. And I feel like a lot of people don't really still understand what these disorders are. And I've actually seen different types of overeating problems, or people with eating disorders will start picking on the ones that barely eat, even though they're overeaters.
So it's almost like, and Cleo, thank you so much for the call, and we hope you and your family have a blessed Thanksgiving. Doctor, she's saying that she likes your knowledge-based approach to this. It's almost like nowadays, you hear somebody's like, "Oh, you're such a picky eater," or you're, "My goodness, you barely got. That's not even enough to feed a bird," or "My gosh, look at your plate." Just stay away from those comments, unless it's a family member that you have an ongoing relationship with and a joke. Kind of stay away from those comments is what I think may help, especially in a situation like this.
Yeah, obviously, if somebody's already in treatment, you can sort of ahead of time speak to family members and let them know, what kind of comments are safe and what kind of comments are not. But, we know that it's actually a minority of patients who get into treatment. The majority of patients with eating disorders never get into treatment, and it can be very hard for them without good understanding from treatment providers to help prepare the families for these situations. So anytime you can remain neutral about food, I would definitely recommend trying not to comment upon other people's eating behaviors.
And especially, I guess, that kind of what Cleo said and what the doctor's saying, you never know. Somebody might have an eating disorder and they've hidden it very well.
Absolutely, Kathy. A lot of times people think that they understand somebody who has an eating disorder by looking at them. Well, you don't look anorexic or you don't look obese. And that is not an accurate way to identify people that have eating disorders. So it is absolutely true that, as the doctor's saying, the more that you can talk about not the physical appearance,
right,
you're going to be far better off. Is there something, doctor, that when somebody does have an eating disorder and whether or not they're in a treatment, you notice that they are struggling? What could a family member say? We already know some of the things you should not say. Is there something that when you can tell that they're clearly struggling, is there something you should say or not do? We were always struggling for that with my niece, Kelly, when she was alive. And I think that was one of our biggest frustrations. We knew she needed help, but we didn't know what was safe to talk about.
Yeah, and that is something that comes up frequently. People feel like they're walking on eggshells around family members. So, my first bit of advice is always just try to simply state the facts instead of jumping to a conclusion, right? So
Very good.
if somebody is, picking at their food or they're eating very rapidly, people will oftentimes say, oh, you've relapsed, or, oh, you're anorexic, or, oh, you're going to binge. I would simply state the facts to what I'm seeing and then ask how I can help. So it could be, it looks like you're really struggling with your food, or I noticed that you're moving that one bite around quite a bit. Is there anything that I could do to help you take, a bite of food right now?
And that's great advice. I mean, that's really tangible advice that we can use this upcoming holiday season. Please stay with us. We've got lots more with Dr. Lutter on JP, Kathy, and the crew on 1160 AM, KBDT News Talk Sports. We'll be right back.
You weren't.
Okay, now we're still on Facebook.
Yeah,
So you
we're-
can still talk.
Okay.
Everybody. So Facebook.
Doc,
This is great advice, because instead of saying, because we're not professionals, I don't know
No.
if somebody's relapsed, but if you take it from the point of view of, I noticed you're pushing the same bite around,
Yeah,
kind of a
but-
thing. It's a different
And that's very
mindset.
specific too, because sometimes people can't really pick up on the generic advice, especially when they don't really understand the disease to begin with.
Yeah, doctor, haven't you found as well there are those patients though who say, okay, I understand that Thanksgiving is coming up and I'm stressed out about it, but at the same time, stop treating me like I'm a patient. I want to be treated like a person. How do you
That's
balance
good.
those two contrary views out? What do you do?
It is a very fine balance, especially for adolescents and young adults who are still kind of relying on their parents for support. So there is this, you don't want to be the food police. You don't want to hover, right?
Yeah.
And at the same time, you also don't want to send the message that you don't care, that they don't have any support whatsoever. So you have to find that balance in between hovering too much and being too overly controlling and letting them have some control over it. And that's going to be largely age dependent, right? So that might involve I always advise that you let people, you give options to patients that you are find acceptable, right? So you want to present them all of the options within the realm of things that you think are realistic, okay? So for a younger patient, it might be picking their side dish, right? You can be like, okay, we're going to have a vegetable. We have 3 different options. What is that pick going to be, right? So you give them in the maximum amount of autonomy.
And is this ahead of time, especially if you know what the menu's going to be?
I would try to do it ahead of time if possible.
And if not
Yeah.
possible, maybe do you pull, because everybody starts to put the food out early. Do you pull them aside and say, hey, here, these are the vegetable options. What do you think?
Most people know the menu days ahead. I would plan it before you even get there, before
Okay.
you even go.
Okay.
That might not be possible, but
Right.
Now, how much of a different mindset is that? Let's say if someone had just been home from a residential treatment program for a week or two, how much of that is a change from what they have been used to for perhaps months, where maybe certain amounts of food are on each plate every day and is highly regulated? How much does that, all of a sudden, that change in life impact the thought process?
1 minute.
yeah. So in treatment, you typically take over control of the meal plan, and you give them food and then gradually relinquish control back so that they have more and more control over that. So it depends sort of where they're on that journey. If they were just out of residential programming where they were being served, maybe off of a menu, that is a case where you're going to have a family member probably plating the food for them, taking the plate, doing the portion sizing. A lot of patients will know what's on their meal plan, but they really struggle to eyeball it, right? They want to weigh the food, which is also not healthy. So later on in treatment, as you progress through and get to lower levels of care, like partial hospital or outpatient, patients do have a better sense of portion size and what is on their meal plan.
And then we've got about 10 seconds. Cleo said,
10 seconds.
what I meant was eating disorders don't happen in a vacuum. People can be trapped during the holidays with other family members who have undiagnosed eating
that on the back.
Good morning and welcome to JP, Kathy, and the crew here on 1160 AM KBDT. We are super excited. Obviously, if you've tuned in on a Tuesday, I was going to say a Thursday, but no, this is Tuesday. It's every Tuesday at 8:34 a.m. We have with us Steve Dunn from the Morgan Foundation and Patty Gillot from Something for Kelly. Of course, we want to thank Acadia, who's a big sponsor of this portion, and we're so proud to be bringing a mental health moment to you every single week. And we're talking about tough topics, but they have to be discussed. And this morning, we were real happy and very thankful, since we're about to have Thanksgiving, that we have Dr. Lutter in studio with us. And he is discussing, he's got a very impressive resume, and he is such the perfect person to talk about this. And that's if you or a loved one have diagnosed or undiagnosed, as Cleo, one of our callers and members of the crew, called in and said, if you've got undiagnosed or diagnosed eating disorder, how do you help yourself or how do you help that loved one?
So the caller wrote back to clarify something, and I don't have it on my screen. Could you?
Yes, Cleo said what I meant was by the eating disorders, they don't happen in a vacuum. People can be trapped during the holidays with other family members who have undiagnosed eating disorders themselves, who push the obvious binge, purge family members buttons. So
that's what I was going to ask the doctor to respond to, because he probably has experience.
We do know eating disorders are largely genetic. The risk of developing eating disorder is between 50 and 70% inherited from your parents.
Wow.
So they do run in families, and it's very common. I have sort of seen two extremes. On one hand, the eating disorder behaviors become normalized. Either as a family, we're a big family, we love to eat, we overeat, or as a family, like we value thinness, we are always underweight, or slim.
Right.
And that can be very hard to deal with, because that then becomes sort of normalized within the family. The other extreme is a lot of times actually family members who've struggled with eating disorders are much more sensitive. They recognize eating disorder behaviors much more rapidly in other family members. They're much more supportive. So it kind of depends on the situation. Obviously, if it's the first case where you have a large number of people engaging the behaviors, it can be very difficult. And we, recommended sometimes that people skip family holidays in those circumstances. So it's kind of on a case-by-case basis.
Okay.
Doctor, let's look at what else can be done to perhaps help families get through, the next month or so. What are your thoughts on having a support person on standby on the phone? Let's say if a person is struggling with an eating disorder, they have a trusted friend that they could call, from whom they get strength or inspiration or words to that effect.
I think that is a great idea. We talked a little bit earlier about having a code word. A lot of patients will have, that they can relate to a parent or a spouse when they are struggling and feeling overwhelmed and need to step away. One step removed from that would be having a support person that you could contact in between family meals. It's not always, readily accessible in the middle of Thanksgiving dinner to get up and call somebody. But the eating disorder community, by and large, is very supportive of one another. And having somebody further along in the recovery, or having an advocate who you can speak with, similar to how the substance abuse community has sort of rallied around themselves, I think is a good idea.
And of course, what are some things that moms and dads can do to really educate themselves about eating disorders and the holidays coming up?
Yeah, so if you have a child, or a spouse, or a brother or sister with an eating disorder, it's always good to try to read a little bit about what's going on, ask them ahead of time what you can do to support them, trying to have a good plan in place as possible, what they need, how, where they are at in their sort of recovery journey, so that you are providing sort of good support. There are a lot of good resources from eating disorder foundations out there that do help educate family members. They are presented at the layperson kind of level, so that they can understand exactly what's going on and what they can do to be helpful.
A lot of times also just generalized around the holidays, anxiety and stress. So don't pile on anymore. Just kind of enjoy the family and don't over stress out about whether or not you're going to go off your meal plan.
That's a good point. That's a good point. Dr. Lutter, how do people get in touch with you?
So my website is precision-psychiatry.com. And you can just search me, Michael Lutter, Lutter, and I kind of pop right up at the top.
I love it. And we will put that on our Facebook Live feed at JP, Kathy, and the crew. Steve and Patty, thank y'all as always. Thank you to the Morgan Foundation and Something for Kelly. Thank you to Acadia. Thank you, Dr. Lutter. We really appreciate you being here with us today. We hope that y'all have a blessed holiday. And thank y'all for helping the crew and those who are in need get through this really, really, really special time of year, because it can be tough. Have a blessed day. We will be back tomorrow with more JP, Kathy, and the crew on 1160 AM KBDT. Okay, and we're clear, but we can still talk to this. So
Ooh, that does go fast.
I know. See, I know. I mean, you're just like, wait, we're done. That's great information. Okay, I'm going to look up your website again. To give that to me again.
Precision and then dash psychiatry.
Okay, perfect. And do y'all want to have any follow-up questions while we're still on
Yeah,
Facebook
just for you.
Live?
First, at this time of the year, around the Dunn household, we always sit around the table on Thanksgiving and say what we're thankful for from this past year. And along those lines, I want to thank Kathy, you, and JP and the show for allowing us to come on and start to bring mental health just out in the public a little bit more. I think it's so incredibly important. And if we can even save one life, if we can help one person because of this, I just can't thank you guys enough.
We're honored to be a show that's able to do that, because if people think that mental illness does not hit every single family, they are sorely mistaken.
Absolutely, Kathy. And well said, Steve. Thank you for thinking ahead and sharing that, because we are truly genuinely grateful to have this opportunity. It means so much to us. And we know we're making a difference because of your reach and because of what you all already know and the very good questions that you and JP can ask. So
thank you very much. Thank you.
Doctor, so, I think we pretty much hit everything that was on the list, but
y'all got a lot in a short amount of time.
Yeah, kept pounding on that one.
The holidays are just so complex. And unfortunately, I got to really know the mind of a person who struggles with an eating disorder every day. Is there anything else you would say, other than moms and dads, educate yourself, read, vociferously read?
We didn't get into binge eating quite as much. What we typically recommend is to try to stick with the lunch, and then have dessert later as your afternoon snack, right? So try not to overwhelm that one meal with all the food, right? So like I said, most people on a binge eating meal plan will have 3 meals and either 2 or 3 snacks a day. So try to do the regular lunch, with your portions, save dessert until the afternoon, have that as your afternoon snack, and then have your regular dinner as you would. And that helps to avoid grazing, right? You don't want to, grazing is a big trigger for overeating.
So grazing not in an anorexic situation, but grazing in the binge purge kind of cycle. So that's bad if you're like standing in the kitchen and snacking on stuff before the meal even starts. Is that what you're saying to watch out for? Maybe go sit in front of a TV or play a game or be off somewhere. Yeah,
grazing, where you're just like nibbling at food all day long.
Right.
We know is a big trigger for binge eating and overeating episodes.
I did not know
trying
that.
to stick to the regular meals as close as possible.
Doctor, what advice would you also give? Because we know that at times after a person does eat, as they do at Thanksgiving or Christmas or that sort of thing, they immediately want to go to the bathroom to allow themselves to purge. How do you keep a person from doing that?
Especially when you're not at your house and you don't have control over, they just went upstairs to a bathroom. I have no control over.
So, the 3 major points we talk about in recovery are structure, support, and accountability. So structure, being on that end, predictability, regular times, support, we talked about, being there, having, the code word or knowing things to say or not to say. We didn't really get to accountability, right? So that's the third piece of how do you keep people on it. So, and you kind of mentioned this a little bit, if you have an older patient or a young adult who kind of wants to take over things on their own, how do you provide accountability, again, without hovering or being the food police? So patients with bulimia, who have self-induced vomiting, are often on what we call bathroom restrictions, where they can't go to a bathroom for an hour afterwards. And I would talk to them ahead of time, just being like, I know this is going to be a difficult time for you, and I know that, you may be tempted to purge afterwards, but I just want you to know that we're going to be watching for an hour after the meal and making sure that you, don't use the restroom during that time.
So is an hour typical?
That's what we typically do at most.
Okay. So
in most
after an
treatment,
hour,
yeah.
it's kind of tough to go in and purge then. Is that what you're saying?
So perhaps during that time period, that hour time period, you can have board games or card games or.
Yeah, distraction is a huge coping skill for most patients with eating disorders.
Yeah.
They also get very worried about talking to family members and what they're going to say. So anything that can distract them away from that, whether it's a board game, the Cowboys game, whatever it is, I would avoid politics.
Oh, that's not
That's a whole
controversial.
nother topic for a whole nother day.
That could make people sick by
Yeah,
itself.
I would definitely have something like that. And the other thing I would say is, if it doesn't go well, that's all right too. Don't try to fight with people or negotiate or get mad or angry. If they're not going to eat or if they're going to binge, it's not the end of the world, right? So what I always tell people is the key to recovery is that there will be setbacks. And instead of using that to reinforce the idea that, there's no way I'll ever get better, this is evidence that, I'm just going to be sick forever. The key is to take that information back into therapy and use that to propel treatment forward, right? So the best
That's a good
information
point.
that we get as therapists come from the setbacks, right? Because then you find out what's really driving the eating disorder. We do these, what we call behavior chain analyses, where we look at the thoughts that they have right before they engage in a behavior, and we can kind of analyze what's really going on. So even worst case scenario, you miss lunch, that's fine.
Yeah.
Don't yell at them and, be like, I knew it. I knew you weren't in recovery. You're going to go back to the hospital. You'll never be, don't use shame. Don't try to manipulate people or coerce them or bribe them or whatever. Just be like, okay, you're not going to eat. That's fine. We'll regroup, and we'll have snack this afternoon, right? Yeah.
And a lot of that though, I wish I had a dime for every time I talk to a mom or dad who are living in this state of constant fear. They fear that their child or their young adult child is going to lapse and then relapse and have to go back again and again and again. They're just operating in this fog of fear. What can you tell them about how to try to push through that to help their kid?
That's tough. So,
It's in 30 seconds.
We've got 5 more hours.
Yeah, no problems.
You did a thesis on this, right?
It varies a lot on stage of life, right? The younger they are, the more control you have over their life, right? So, like the 12, 13, 14-year-old, it's much easier for containment. As they get to be older, and especially, that 18 to 22-year-old range, it is a notoriously difficult time because, they think they're adults now and they, will often think that they should be in control of their treatment, but they're still relying on mom and dad, right? Especially for family, for financial support, but also for emotional support and decision making. So, I really think of it at like 3 stages. At the younger stage, that middle school, young high school age, you're going to try to wrap around with maximum support and maximum containment. Okay. And for the most part, you can stabilize those situations pretty easily. For the older age, kind of what I specialize in, is going to be, 25 to mid 40-year-old women who are going to be newly married in relationships kind of on their own. It's a much different approach, right? With a 13-year-old, you can threaten to take their iPhone away if they don't eat, right? For a 35-year-old professional with a job, if I threaten to take their iPhone away, they're going to laugh at me.
Yeah, I pay for my phone, so thank you very much.
Right?
Yeah, exactly. Yeah.
So that is a much different approach, a husband versus a father, a brother, versus an uncle or something like that. And there you really have to form an alliance with the patient. You have to align the goals. Like I said, I would never agree to a treatment plan that I don't think is reasonable, but in behavioral health, there's oftentimes many options that are reasonable, right? From sort of most conservative to most aggressive options. Sometimes people are medically unstable and you're like, look, you've got to go to the hospital, right? I had a patient come in last month who was 56 pounds and she wanted outpatient treatment. And I'm just like,
yeah, wow.
yeah. And I'm like, I cannot ethically do that. You need, to go a higher level of care. But most patients, like I said, there's a spectrum of care. You present the options and you try to align your goals with their goals. And in those cases, what I typically say is people want to get better. Most people don't want to think about food 90% of the time. They don't want to be binging and purging. There's something blocking them from being successful. And my job with the older patients is to remove the roadblocks, the hurdles to them being successful, whether it's body image distress, or distortions, whether it's depression or anxiety, whatever it is, I try to remove the